When using the FIGO systems, first start by obtaining a structured menstrual history, identifying the frequency, duration, regularity, and either the patient's perception of volume or, in the circumstance where there are opportunities to measure volume, the measured volume. In addition, any complaints of intermenstrual bleeding should be identified, and it should be determined whether this bleeding is random or occurs consistently in the early, mid, or late cycle. After the structured history is obtained, one can begin the investigation to determine what components might be responsible for the patient's abnormal uterine bleeding. Imaging designed to identify polyps, adenomyosis, leiomyomas, sampling to determine whether there is endometrial hyperplasia, a screen for coagulopathy, ovulatory dysfunction is from the structured history, determination of whether or not a primary endometrial defect is present, a history suggestive of iatrogenic gonadal steroid induced abnormal bleeding, and there are other entities that have not yet been classified in the system. Should leiomyomas be identified, then the investigation should be carried out as appropriate to determine the type, submucous or other or outside the endometrial cavity, and if they are submucous lesions, how much of the lesion is involved in the myometrium. All of these are important when trying to determine the most appropriate intervention. The coagulopathy is determined by a structured screen found elsewhere on this website in the investigation toolbox. The investigation can be documented in the form of a grid. At the beginning, nobody knows what, if any, findings will be identified. In this patient, who is a 41-year-old single, para 0020, she has cyclic heavy menstrual bleeding every 30 days for 6 days with clotting and cramping days 1 to 2 for 2 years. She has a negative coagulopathy screen. She had an endometrial biopsy and it showed luteal phase endometrium. She's also undergone an infertility investigation that suggested that there was a leiomyoma on the hysterosalpingogram with patent tubes and a normal semen analysis. The negative coagulopathy screen allows us to say that the patient doesn't have a coagulopathy. The cyclic heavy menstrual bleeding allows us to say that she doesn't have an ovulatory disorder. She's taking no medications that would affect bleeding, so I is not present. A 41-year-old with cyclic heavy menstrual bleeding and a normal endometrial biopsy doesn't have hyperplasia or malignancy. A contrast ultrasound demonstrates a submucous leiomyoma. And here is the same image stylized, a type 1 lesion. So now we can populate the rest of the matrix. There's no polyp, there's no adenomyosis, there is a leiomyoma, and it is a submucous leiomyoma. The patient doesn't have any other identified unclassified entities, and as far as we know, she doesn't have AUBE. So this is a very simple way of working through a relatively simple situation. Here's another patient. 23-year-old, has never been pregnant, has irregular menstrual bleeding every 20 to 70 days times 2 to 8 with clotting. She wants to preserve fertility. She has chronic difficulty with facial hair. Her BMI is 32 and her hemoglobin is 9.4. So what can we determine from this? Well, we don't think that she has a coagulopathy. She failed the screen, but she does have an ovulatory disorder, it would appear. We can't determine that she has an endometrial problem, at least one that's primary, and she's not taking any medications that would affect bleeding. When we perform a standard transvaginal ultrasound, we identify a type 6 leiomyoma, well away from the endometrial echo complex demonstrated here. This image is stylized in this graphic. So now we can populate the rest. At her age, malignancy can be largely excluded. She doesn't have a polyp, she doesn't have adenomyosis, and she does have a leiomyoma, but it's outside the endometrial cavity. And there are no other identified abnormalities. So likely, therapy for this patient can be directed at the ovulatory disorder if we assume that the leiomyoma is asymptomatic. The third case is a 36-year-old nullogravid with lifelong cyclic heavy menstrual bleeding every 28 days. It's even been getting worse over the past 5 years. They're still 8 days in length and heavy, but now with clots for 4 days. She has always had dysmenorrhea throughout her period, but it is now severe enough to impact work for 3 days per cycle. A district attorney, she has been putting off pregnancy, but desires to preserve fertility. She has been using condoms for contraception. So what can we tell? Well, first of all, she fails the screen. And an individual like this should have investigations to determine if indeed she might have a coagulopathy. The results shown here confirm that she has von Willebrand's disease. What type should be determined in conjunction with consultation with a hematologist. But we can at least put an X by coagulopathy. She doesn't have an ovulatory disorder. She's not taking medications that would affect bleeding. And she doesn't have a malignancy given the cyclic nature of her bleeding. But if we image her, we see the following. A very large area of heterogeneous myometrium, stria, and even some tiny cystic spaces. All of these are consistent with adenomyosis. Note the thickness of the posterior myometrium. So we depict the adenomyosis here. So now we can populate our matrix with adenomyosis, no leiomyoma, no unclassified lesion, and of course we don't know that she doesn't have a primary endometrial defect, but we do not think that she has one based on this assessment. So the treatment of this patient will have to consider both of these possible contributors to her heavy menstrual bleeding. The final case is a 38-year-old who's newly remarried, has had one previous pregnancy. She's had 3 years of cyclic heavy menstrual bleeding every 28 days for 7 days with clotting and cramping. Her coagulopathy screen was negative. She's a teacher. She's considering pregnancy with her new husband. She's been using a CUT380A Paragard copper IUD for contraception. So what do we know from here? Well, she could have the IUD as a contributor to the bleeding. She doesn't have a coagulopathy. She doesn't have an ovulatory disorder. And given the story of cyclic bleeding, malignancy or hyperplasia is highly unlikely. And here is a graphic depicting what is going on with this patient. So now we can populate. She has no polyp, no adenomyosis. She does have leiomyomas, but they're all outside the endometrial cavity. She doesn't have AUBE as far as we can tell, and there are no unclassified lesions. So in discussing this woman's future, it may be that her IUD just needs to be removed so she can go on and try to conceive, and the leiomyomas may not have anything to do with fertility downstream.